Good afternoon, everyone. My name is Brad Rovin. I'm the director of the Division of Nephrology at The Ohio State University. And today I'm going to discuss the 2020 KDIGO Guidelines for the treatment and management of glomerular diseases. And specifically, in this part of the discussion, I'm going to focus on lupus nephritis, ANCA-associated vasculitis, anti-GBM disease, and the immunoglobulin and complement-mediated glomerular diseases. Formerly, the chapter was called Mpgn. So I'd like to start with lupus nephritis, and you can see at the left, I've indicated the members of the work group for each of these diseases who actually put these guidelines together. And I want to start with the general recommendation for lupus nephritis, which a lot of nephrologists may not actually be familiar with, although it's well known to rheumatologists. And this is a real recommendation that has a fairly good evidence base. So we ranked it as a 1C recommendation. And we suggest or recommend that patients with lupus and lupus nephritis be treated with hydroxychloroquine or an equivalent antimalarial unless contraindicated. Now, I want to show you some data to support that. And these are both cohort studies that examined the incidence of developing lupus nephritis in patients with systemic lupus, or if the patients had lupus nephritis, developing end-stage kidney disease, or whether or not, or the chances of developing a complete renal response if the lupus nephritis patients were treated or not treated with an antimalarial. In the first cohort, the Gladel cohort, you can see that if you had lupus, the odds ratio for developing lupus nephritis, if you were on an antimalarial, was 0.38, which indicated a substantial degree of protection in those patients taking the antimalarial, and this was statistically significant. In the Rensselaer cohort, you can see similarly a very good and low odds ratio for developing lupus nephritis in patients with lupus. They also examined the chances of a lupus nephritis patient going on to end-stage renal disease. This was markedly reduced, as shown in the middle column. And then in the last column, you can see that the odds ratio for a complete response when the patients were treated actually improved greatly in patients who had antimalarial in their background. So we recommend that all patients with lupus and lupus nephritis be treated with an antimalarial. This is a practice point rather than a recommendation, and I suspect most people know in the nephrology community about adjunctive treatments in managing patients with glomerular disease. I just want to point out a couple of important considerations in the lupus population. Lupus patients are at higher risk than the age-based and sex-based matching population for cardiovascular disease because of the lupus. We do recommend the usual sorts of lifestyle modifications that one would consider for patients at risk for cardiovascular disease, but also because of an increased risk for clotting, we recommend the use of low-dose aspirin during pregnancy. I've outlined in infection risk the entire panel here as something we should keep a close watch on. And because lupus patients are going to be treated, lupus nephritis patients are going to be treated with significant immunosuppression, it's really relevant to know if they've had a history of herpes zoster or tuberculosis prior to starting immunosuppression. It's also important to screen for hepatitis viruses, and this is especially true because in the setting of treatment with rituximab, which some people will use to treat lupus nephritis, hepatitis B can reactivate. also, depending on the time of the year and the patient's status, influenza and pneumococcal vaccination should be considered. And then, of course, we now have a recombinant herpes zoster vaccine that can be considered in some patients. To prevent bone injury in patients that you think will be on corticosteroids for a long period of time, calcium and vitamin D supplementation should be considered. Again, in the rheumatology community, this is well known, but maybe less so in the nephrology community. Exposure to ultraviolet light can actually trigger systemic lupus in the susceptible patient. And so broad spectrum sunscreen of a high protective ratio is recommended for our patients. Premature ovarian failure is not necessarily a consequence of the disease, but more a consequence of our therapies, especially if cyclophosphamide is used. And this discussion should be had with all patients who are going to be put on cytotoxic therapy. And one of the most effective methods, albeit somewhat expensive, is sperm or egg donation. And cryopreservation. So that is something that should be considered for all patients of childbearing age who might want to have a family when the lupus goes into remission. And finally, just to refresh everyone's memory, cyclophosphamide results or can lead to other malignancies in the future. And so we recommend that limiting the lifetime exposure of cyclophosphamide to less than 36 grams. Okay, this is an algorithm of an approach to the management of class 1 and 2 lupus nephritis. We call this a practice point because we don't have the significant evidence that we would like to validate this algorithm. Nonetheless, we think this is a reasonable way to approach patients with class 1 and 2 lupus. And for these patients, mostly, you will almost never see a class 1 patient because they generally don't have clinical indications to do a kidney biopsy. And if you happen to have a patient with proteinuria who is biopsied and the proteinuria is low level and they turn out to be class 2, in general, the immunosuppressive treatment should be guided by the extrarenal manifestations of lupus as opposed to specifically treating for a lupus nephritis. Now, what I do want to point out is that occasionally patients can have a class 2 histology, but actually have nephrotic syndrome. And in this particular subset of patients, it's important to do electron microscopy if available to look for lupus podocytopathy. And the lupus podocytopathy usually appears to be a FSGS lesion or a minimal change lesion. And we do recommend or suggest that patients with a lupus podocytopathy be treated as one would for minimal change disease. And usually corticosteroids are the first line of treatment for these patients. Often this resolves unless they have a focal segmental glomerulosclerosis pattern, which is much harder to treat. And you could consider maintenance therapy with a low-dose steroid and possibly another immunosuppressive agent like mycophenolate if needed. This is an algorithm which demonstrates the management of patients with proliferative lupus nephritis. So this is class 3 or class 4 lupus nephritis with or without class 5. And I'll just go through the algorithm briefly. Despite all the news and all the clinical trials that you've heard about testing therapies in lupus nephritis, we're still sort of left with a couple of basic immunosuppressive regimens at the present time for lupus nephritis. And we'll go over the future at the end of this section about what you can anticipate over the next several months to years. But in general, one should start the evaluation for a proliferative lupus nephritis by looking at the activity and chronicity indices of the kidney biopsy. If the kidney biopsy shows only a chronic class 3 and 4 plus class 5 and there's no current immunologic activity, supportive treatment for any chronic kidney disease is appropriate. And if the class 5 is still active, in other words, there are still subepithelial immune complexes as opposed to reabsorbing immune complexes, and the patient is still proteinuric, then consider a management scheme for class 5 alone, and we'll discuss that in a little bit. If the patients have active class 3 and 4, then you need to decide whether or not you're going to give methylprednisolone. In the old literature, we used to recommend methylprednisolone at a dose of 1 gram a day for 3 doses. This is probably a substantial excess of methylprednisolone, although in some cases, depending on how severe and rapid the progression of the disease, this could still be used. But more often, we recommend methylprednisolone at 250 milligrams to 500 milligrams a day for 1 to 3 doses, and then switching over to oral prednisone or the equivalent of prednisolone, 0.6 to 1 milligram per kilogram per day, and this is tapered over a few months to maintenance therapy. Then the immunosuppressive choices that can be added to the steroids for proliferative lupus nephritis include various formats of cyclophosphamide. So intravenous cyclophosphamide at high dose, which is generally termed the NIH cyclophosphamide protocol, oral cyclophosphamide, or the increasingly used low-dose cyclophosphamide, which also is known as Urolupus cyclophosphamide. And we'll focus on this because this is the basis of our recommendation. Low-dose cyclophosphamide is 500 milligrams every 2 weeks intravenously for a total of 6 doses. And that will give you the equivalent of only 3 grams of cyclophosphamide. This would compare to about 6 to 9 grams for NIH cyclophosphamide, depending on the level of dosing used, and 9 grams or so for oral cyclophosphamide. Besides cyclophosphamide, one can start with a mycophenolic acid derivative, often mycophenolate mofetil, and occasionally mycophenolic acid. We have not put into our top line recommendation multi-target therapy, that is a calcineurin inhibitor plus a lower dose of mycophenolate plus a lower dose of steroids, but I will discuss this option a little bit later in this session. So the recommendation that will be stated in the guidelines is we recommend that patients with active class 3 or 4 lupus nephritis, with or without a membranous component, be treated with corticosteroids plus either low-dose intravenous cyclophosphamide, so the Urolupus regimen, or mycophenolate in either format. And this is given a 1B rating. This is the most highly rated recommendation in the lupus induction therapies. Now, some of the data behind why we chose low-dose cyclophosphamide as opposed to usual or high-dose cyclophosphamide are many of the emerging studies showing that it is provides equivalent efficacy as higher doses of cyclophosphamide with a lower lifetime exposure, less incidence of infertility, and fewer potential immunosuppressive side effects. Some of the initial concern about low-dose cyclophosphamide was that it was tested originally in a mainly white European population, and the results were shown to be similar to the NIH cyclophosphamide protocol. But as time has gone on, other populations have used low-dose cyclophosphamide with different ethnicities and races and have found fairly comparable results with higher doses of, with higher doses of cyclophosphamide. So there's several caveats that we have outlined as practice points that one can consider in the initial management of active lupus nephritis proliferative. And here I've shown you that a reduced dosing of corticosteroids may actually be considered. Now, the standard dosing of corticosteroids is shown here, is generally what we've traditionally used in the management of lupus nephritis. But as you know, this leads to innumerable adverse events, and patients generally are very unhappy taking high doses of corticosteroids. Several recent trials have indicated comparable efficacy when starting out with a much lower dose of corticosteroid and a much more rapid taper. And this is a regimen that we think is an effective regimen and exposes the patient to less cumulative dose of the glucocorticoid. Now, we have a number of caveats and practice points that I don't want to go through in detail, but a couple of things just to point out. As you know, one of the biggest problems in the management of lupus nephritis is adherence to the regimen, and we suggest that intravenous cyclophosphamide be used in patients that you anticipate might have a difficulty being adherent to oral medications. In patients who do have high risk of infertility, patients who have already had a moderate or high cumulative dose of cyclophosphamide, and patients of Asian, Hispanic, or African ancestry, we suggest starting off induction therapy with a mycophenolic acid derivative. Calcineurin-based triple therapies at the present time we're suggesting be reserved for patients who cannot or will not use a standard mycophenolate or cyclophosphamide-based treatment regimen, but this may change in the future, as we'll discuss shortly. Other therapies are used in different parts of the world, and they can be considered in patients who don't have access to or do not tolerate the recommended therapies. And the place of biologics in the initial treatment of proliferative lupus nephritis is evolving. And while we're not ready to recommend as first-line therapies, these can be considered for individual patients. Okay, the other 1B recommendation that we have in the lupus guidelines is that after completion of initial therapy, patients should be placed on mycophenolic acid derivative for maintenance therapy. And this is an algorithm that shows that. Prednisone will be tapered down to a low dose, and then the first choice for maintenance therapy is maintenance with MMF or MPA. Azathioprine can be substituted depending on individual indications. And then if mycophenolate or azathioprine are not tolerated, consider a calcineurin inhibitor, and mizorabine is available in some countries, but not most. Some of the caveats for this are as follows. Azathioprine is a viable alternative to mycophenolic acid derivatives in patients who don't tolerate this, don't have access to these derivatives, or patients who are considering pregnancy, because azathioprine can be used in the pregnant patient. Except when corticosteroids are required for extrarenal manifestations, gradual tapering of corticosteroids and with the goal or aim of discontinuing the steroids after patients have maintained a complete remission for at least 12 months should be considered. The main practice point that I wanted to emphasize, and I put this in red, is that we don't really know how long maintenance should be continued in patients with lupus nephritis. And while patients often remain on some form of therapy for several years and sometimes indefinitely, what we do understand from the emerging literature is that a minimum of 36 months of immunosuppression is generally required in patients to ensure a good and sustained complete or very good partial remission in patients with lupus nephritis. So you need, as you're counseling patients, you need to sort of tell them that this is a long-term investment to get the kidneys to a point where immunosuppression can be considered to be tapered off. Okay, moving to class 5 or membranous lupus nephritis, there is very little evidence that is high quality, in other words, randomized controlled trials, to guide the therapy of these patients. We divide patients with class 5 into patients with nephrotic syndrome or nephrotic range proteinuria or lower levels of proteinuria. Patients with other than nephrotic syndrome, the recommendation is to use antiproteinuric therapies such as renin-angiotensin, aldosterone system blockade, excellent blood pressure control. Immunosuppression should be guided by the extrarenal manifestations of lupus. And again, these patients should be on an antimalarial. On the other hand, if patients do display nephrotic syndrome in class 5 lupus nephritis, again, conservative or general antiproteinuric therapies are appropriate. These could be combined with an immunosuppressive treatment, often with glucocorticoids and one other agent. A mycophenolic acid derivative or cyclophosphamide are often used. Case can be made for calcineurin inhibitors as well. And certainly there are data, albeit not with randomized controlled trials to date, using rituximab and azathioprine. And of course, hydroxychloroquine. There are several caveats to be realized. We have defined in the practice points complete response, partial response, and no renal response. These are fairly standard definitions that are used in many clinical trials that are being conducted recently or currently. For the complete clinical response, this is generally driven by reduction in proteinuria to less than 0.5 grams per day, stabilization or improvement of the serum creatinine, and this should really occur within the first 6 to 12 months of starting therapy. But the reality is it very seldom occurs within 6 months, and it can take longer than 12 months. So some measured waiting is appropriate if patients are getting better. Partial remission is generally defined as a reduction in proteinuria of at least 50% and to less than 3 grams a day if the patients had been had nephrotic range proteinuria prior, and then a stabilization of kidney function. No renal response is the absence of complete or partial renal response. This last practice point I want to discuss is an algorithmic approach to patients who don't achieve a complete or partial response, and what things that could be considered to sort of manage these patients. And number one is to verify adherence to treatment. And this sort of segues with number two. When studies are done, the adherence to lupus regimens is in the 40 to 60% range. So the very first thing that should be considered in patients that are not responding well is whether or not they're actually taking the medication as prescribed. One way to actually check this and to see if the dosing that you've given the patient is adequate is to measure plasma drug levels if available and applicable. For example, mycophenolic acid levels can be measured, hydroxychloroquine levels can be measured. If there's concern for an additional process, for example, a very chronic lesion has developed and inflammation is not as evident, a repeat kidney biopsy could be useful in helping you discern that. If another diagnosis is considered, for example, a superimposed thrombotic microangiopathy, consider another biopsy. When patients have not responded after an adequate trial to first line, your first choice of first line therapy, such as cyclophosphamide or MMF, then next, consider going to the alternative first line therapy. So if you started with cyclophosphamide, switch to MMF or vice versa. If that does not actually achieve a complete or partial remission, then patients should be considered refractory to first-line treatment regimens, and other therapies can be considered. Now, I don't have time to go into the management of refractory lupus nephritis today, but listed below are some of the choices, and I'll just point out that rituximab with less than randomized controlled trial data has often been used in this setting. There's been a renaissance in lupus nephritis therapeutics, with many clinical trials having been done recently, and in the last year, several successes. And I just want to point these out because as these trials come to end and are taken to the FDA and other regulatory organizations, it's entirely possible that we will have new drugs approved for the treatment of lupus nephritis. I'll point out data. This is data from the phase 2 multi-target approach using mycophenolate plus the novel calcineurin inhibitor voclosporin plus a low dose of prednisone. And as you can see here, that at 24 weeks, the low dose of voclosporin actually resulted in a significant improvement in complete renal remissions at 24 and 48 weeks. Now, the important point is that a phase 3 trial using this regimen was recently completed, and although we don't have the data published yet, the phase 3 trial was positive. The results in the phase 2 trial were confirmed in the phase 3 trial, and this is now undergoing or progressing towards a regulatory consideration. So this may be something to look at in the not too distant future. This is also a results of a phase 2 trial that were presented last year at the American Society of Nephrology meeting. Obinutuzumab is a drug that is much like rituximab, although it has a much higher complete B-cell depletion ability. Obinutuzumab added to standard of care was tested in a phase 2 trial, and the standard of care in this case was mycophenolate. And you can see that as time went on, and these are the 76-week results, that the patients with Obinutuzumab had a significantly higher complete renal response than the patients treated with placebo plus mycophenolate. Importantly, a phase 3 trial is now underway using this therapy, and that is a large randomized controlled trial. Also, there are 2 other phase 3 trials that are finished or finishing up and that will be set to report soon. The first is the addition of belimumab to standard of care therapy for patients with lupus nephritis. And this trial has been completed. And if you've followed, I don't have data to show you because this is not public information yet, but the press releases indicated that this was also a positive trial. And then the addition of anti-interferon alpha plus standard of care, the so-called TULIP trial, is set to report soon. And as you know, the non-renal study using the anti-interferon alpha monoclonal antibody anifrolumab was actually reported in the New England Journal a few months ago, again as a positive trial. So this gives us some hope that we're going to see several new potential therapeutics for patients with lupus nephritis, which will require a revision of the guideline very quickly, but will hopefully be to the benefit of our patients. Okay, I'd like to move on and show you just an algorithm now for rapidly progressive glomerulonephritis. And there's an emphasis that I think we need to make here so that these patients are managed correctly and damage to the kidney is minimized. So if you have a patient with a rapid decline in kidney function, of course a urinalysis should be done. If the urinalysis is not positive for blood or protein, then evaluate for a non-glomerular etiology of acute kidney injury. But if there is blood and protein on the urine, look for glomerular hematuria in the urine sediment or pyuria without any evidence of urinary tract infection. This would be very good evidence that there's a glomerular process going on, and one should consider a rapidly progressive glomerulonephritis. At that point, and this should all happen fairly quickly, serology for anti-glomerular basement membrane antibodies, ANA, ANCA should be sent off. Infections should be excluded, and a kidney biopsy should be done. Now, this is really the important point, is that if a patient has a rapid deterioration of kidney function and these data or the kidney biopsy cannot be done quickly, treatment should probably not be delayed waiting for these to come back. If the data can come back within 24 hours, then you can specifically start a specific therapy for the diagnosed disease. However, if the data are not going to be back in 24 hours, the kidney biopsy cannot be done quickly, then it's prudent to initiate treatments to decrease the inflammation and preserve renal parenchyma. So in this setting, steroids will be given to most patients, and these are often anti-inflammatory doses or high doses of steroids. Plasma exchange should be started if an anti-glomerular basement membrane glomerulonephritis or Goodpasture syndrome is suspected. Sometimes these patients are very difficult it's very difficult in these patients to exclude infection. And so if infection is suspected, then something that could be done quickly that is immunomodulatory but will not worsen the infection while the diagnostic workup is ongoing is to use therapeutic doses of intravenous immunoglobulin. But the main point of this algorithm is not to delay therapy while waiting for diagnostic confirmation of the disease process, because you lose valuable time and the patient could be having irreversible damage to the kidney. So one of the RPGNs, or rapidly progressive glomerular diseases, of course, is anti-GBM nephritis. There's not a lot new in anti-GBM disease. We still recommend to initiate immunosuppression with cyclophosphamide and corticosteroids, plus plasmapheresis to remove the pathogenic antibodies in all patients except those who are dialysis dependent at presentation and who have 100% crescents in an adequate biopsy sample and do not have pulmonary hemorrhage. The point or the interpretation of this recommendation is that if the patient has anti-GBM disease, it's isolated to the kidney, and they have dialysis dependence from the start of presentation and crescents throughout the kidney, the chances of them recovering is very small. And unless they have a component that requires immunosuppressive therapy, such as pulmonary hemorrhage, the risk-benefit ratio of adding immunosuppression is probably not favorable. And so this is why we suggest not using immunosuppression in such patients. Again, several practice points for anti-GBM disease. I highlight a couple, but I just want to make this point. Plasma exchange should be performed until anti-GBM titers are no longer detectable. And sometimes this is a difficult task. You have to work with your apheresis people. No maintenance therapy of anti-GBM disease is necessary. If you have pure anti-glomerular basement membrane, glomerular nephritis, these patients tend not to relapse, and maintenance therapy is not necessary. However, a fair percentage of patients will actually have anti-GBM antibodies and will be positive for anti-nuclear cytoplasmic antibodies. ANCA, as you know, is a relapsing disease, and if both of these are present, then the patient should be treated with maintenance therapy, as will be discussed for Anchorvasculitis. And the last practice point that I want to emphasize is kidney transplantations in patients who have kidney failure due to anti-GBM disease should be postponed until GBM antibodies are undetectable for at least 6 months. And this is an important point because you'll see a little bit of a contrast in the recommendation for when to transplant patients with ANCA antibodies coming up. I want to point this out. There hasn't been a lot of new therapies tested for anti-GBM disease. It's a rare disease. It's hard to do trials. But imlifidase is a IgG degrading peptidase that's derived from a strep bacteria. And this is a very interesting concept. This peptidase cleaves human IgG into Fab2 fragments and FC fragments, and inhibits then antibody and complement dependent cytotoxicity. So it was postulated that treating patients with anti-GBM disease could, with this peptidase, could very quickly destroy the anti-GBM antibodies and allow them to be cleared, thus immediately relieving the pathogenic antibody effect on the kidneys and the lungs. And it turns out this was a preliminary study, very preliminary. But this treatment was given to 3 patients with anti-GBM disease. Now, they were dialysis dependent, and none of them recovered independent kidney function. Probably they weren't going to recover independent kidney function anyway, being dialysis dependent. But what was noted was that these patients had an immediate clearing of anti-GBM antibodies from their circulation after the administration of this endopeptidase. So this has prompted a clinical trial that's currently underway to examine the efficacy and safety of this peptidase in anti-GBM disease. So this may be an exciting future development for patients with Goodpasture's syndrome and anti-GBM GN. Okay, moving to Anchorvasculitis, another RPGN. Again, emphasizing, this is a practice point, but we're emphasizing that in patients with a clinical presentation compatible with a small vessel vasculitis, and especially in combination with PR3 or MPO ANCA serology, waiting for a kidney biopsy to be performed or reported out should not delay starting immunosuppressive therapy. And that goes especially for patients who are rapidly deteriorating. The induction treatment of Anchorvasculitis is, our recommendation is corticosteroids in combination with cyclophosphamide or rituximab. And this is again, an evidence-based 1B recommendation. Now, choosing between rituximab and cyclophosphamide is not necessarily straightforward. We've created a table to sort of give some preferences. Children and adolescents, rituximab may be preferred. People who are concerned about fertility and don't want to be exposed to cyclophosphamide, this is a good option. Patients who are very elderly, you may not want to treat with cyclophosphamide. Patients in whom glucocorticoid sparing is important. We do know that in a head-to-head comparison, rituximab is preferred for patients with relapsing disease as opposed to de novo disease, and possibly in patients with PR3 ANCA as opposed to MPO ANCA. A couple of areas where cyclophosphamide may be preferred. Hepatitis B exposure, hepatitis surface antigen positive. Again, hepatitis B can be reactivated and be severe in patients treated with rituximab. And so in a hepatitis B positive, surface antigen positive patient, antivirals should be considered to be started along with rituximab if rituximab therapy is necessary. In some cases, rituximab is difficult to gain access to and it's expensive, but this is the most important caveat. The trials that have compared cyclophosphamide to rituximab head-on for Anchorvasculitis, the main trial, the RAVE study, did not look at patients with severe renal dysfunction at the time of presentation. So in other words, patients who had a serum creatinine at diagnosis greater than 350 micromole per liter. The Rituxavasc trial did look at those patients, but used rituximab in combination with at least 2 intravenous pulses of cyclophosphamide. So in patients with severe renal insufficiency at the time of initiation of therapy, at present, the preference is to start with cyclophosphamide. There's also a futility consideration to think about during induction. And we chose this as a practice point because the evidence is not outstanding, but consider discontinuing immunosuppressive therapy after 3 months in patients who, with Anchorvasculitis, remain dialysis dependent, but only in those patients who don't have any extrarenal manifestations of disease. So in other words, if the Anchorvasculitis is confined to the kidney, there's no ENT or pulmonary manifestation, something else that would make you need to consider high-dose immunosuppressive therapy, and the patients need dialysis from the beginning and don't really come off or improve after 3 months of good immunosuppression, then consideration should be given for reducing immunosuppression because the risk-benefit ratio is not in favor of continuing. Plasma exchange for ANCA-associated vasculitis is a very controversial point. New studies have come out, and I just want to summarize them and how they're being interpreted at the present time. We still put into the guidelines the practice point that we should consider plasma exchange for patients requiring dialysis or with rapidly increasing serum creatinine, and into patients with diffuse alveolar hemorrhage who are hypoxic. Now, plasmapheresis, as I said, remains controversial. Earlier studies, such as MEPEX, suggested a benefit in kidney outcomes for patients presenting with severe kidney failure and a high serum creatinine. A meta-analysis of plasma exchange, plasmapheresis studies also suggested a reduced incidence of end-stage kidney disease at 12 months. However, Pexavasc, a trial that we've been waiting for a long period of time, was recently reported, and it looked at plasma exchange in patients presenting with an eGFR less than 50 or alveolar hemorrhage. And it was found that the addition of plasma exchange did not delay the time to end-stage kidney disease or death over a median follow-up of about 3 years. So this was a negative study suggesting plasmapheresis was not effective. However, there are certain caveats to think about when interpreting these data. No kidney biopsies were required for the trial. So patients with poor kidney function due to chronic damage really couldn't be distinguished from patients with poor kidney function due to inflammation and disease activity as opposed to chronicity. A subgroup analysis suggested that patients with severe pulmonary hemorrhage could benefit from Plex. As you can see, those patients who were given Plex had a hazard ratio of 0.67, suggesting benefit. However, the confidence intervals were wide. So while Plex probably should not be routinely added to patients with ANCA-associated vasculitis and kidney failure, certain subgroups could benefit. For example, patients with very active kidney disease, very little chronicity on biopsy, and plasma exchange should be considered in those patients. So we still have a ways to go in understanding plasma exchange in all groups of patients with Anchorvasculitis. Maintenance therapy for Anchorvasculitis, Rituximab or azathioprine, along with low-dose corticosteroids, can be used for maintenance after induction of remission. Several practice points with this recommendation. A couple of very important ones that I'd like to point out. After rituximab induction, maintenance immunosuppression should be given to most patients as opposed to not giving any maintenance therapy. There are some patients, especially MPO ANCA patients, who have a very low or a lower incidence of relapse. And there is consideration that those patients could be watched without further immunosuppressive therapy. But in general, most patients will need some immunosuppressive therapy. We don't really know the optimal duration of azathioprine plus glucocorticoids or rituximab. Generally 18 months to 4 years have been used for azathioprine and 18 months for rituximab so far. This is a difficult decision. It's similar to lupus, where we don't know how long maintenance therapy should be continued. In my own practice, I tend to use rituximab for a period of at least 18 months of complete response before considering elimination of immunosuppression and longer in patients with PR3 Anchorvasculitis. Importantly, there's no role for routine use of an oral corticosteroid in rituximab maintenance. And so this is important for patients and because of the side effects of glucocorticoids. So the preferred maintenance immunosuppression more and more is looking to be rituximab. Here's some guidelines or suggestions on where rituximab may be preferred over azathioprine. I think, again, I'll only point out that azathioprine may be preferred in patients with hepatitis B surface antigen positivity because of the possibility of the disease becoming very active in the setting of rituximab therapy. Risk factors for relapse should be considered. These are baseline factors for relapse. As I noted before, patients with PR3 ANCA tend to relapse more than patients with MPO ANCA. Patients who have ENT disease actually tend to relapse more as well. After the diagnosis of Anchorvasculitis, patients with a history of relapse tend to relapse more. A rise in the ANCA titer or continued ANCA positivity at the end of induction therapy also are indicators of potential risk for relapse. And then, of course, treatment factors, lower total cyclophosphamide exposure in patients treated with cyclophosphamide. And of course, anybody who has an immune disease with immunosuppressive withdrawal should always be followed carefully for relapse. As opposed to patients with anti-GBM disease, the practice point or suggestion from the group is to delay transplantation until patients are in complete remission for 6 months. But if they are in complete clinical remission but still remain ANCA positive, do not delay transplantation. The recurrence rate is very low. Now, again, like lupus, there's been interest in new therapies for Anchorvasculitis. I'm showing you the data from the phase 2 trial of a C5a receptor antagonist, so complement component 5a receptor antagonist. This was published a few years ago, and in essence, patients were treated with standard of care, which was either cyclophosphamide plus steroids or rituximab plus steroids, and then these were the control group. And then patients were either randomized to a low-dose prednisone group plus the C5a receptor antagonist avacopan, or a no steroid group plus the C5a receptor antagonist. And just looking at the change in albuminuria from baseline over the first 12 weeks, you can see that this is the group, that is the placebo, so this is the standard of care group. Both groups treated with the C5a, the complement receptor antagonist, actually outperformed the placebo group over the first 12 weeks in terms of reduction of proteinuria. Importantly, this then was studied in a pivotal phase 3 trial called Advocate. And although we don't have the publication yet or the data out from the company press release, the Advocate trial met its primary endpoints of remission at week 26 and sustained remission at 52 weeks. And these are the data that were given in the press release. Hopefully this will be published in the not too distant future. 72% of the avacopan treated patients who were on a lower dose of corticosteroids remitted at 26 weeks, compared with 70% of the participants. So decreasing steroids was equivalent in the avacopan group. And then this was extended over 1 year. And in fact, the avacopan group actually, more patients remained in sustained remission than those treated with standard glucocorticoid therapy. This should also suggest to you that maybe we are using too much corticosteroid in our patients with Anchorvasculitis, just as some of the data are showing for our patients with lupus nephritis. And if you look at the Pexavast trial, one of the other things they did in addition to examining the effects of plasma exchange was they compared a routine steroid taper to a rapid steroid taper. The rapid steroid tapering group did as well as the routine steroid tapering group, but cumulatively they had a 40% lower corticosteroid exposure, again suggesting and consistent with the idea that we can reduce steroids without any compromise of efficacy in some of these patients. Okay. The last section I'd like to discuss today is our new chapter called Immunoglobulin and Complement-Mediated Glomerular Diseases with an Mpgn Pattern of Injury. And so we've taken a chapter that used to be called Management of Mpgn and renamed it with a very lengthy title. And there's a rationale for that. As you all know, Mpgn, membranoproliferative glomerular nephritis, is not actually a disease. It's a pattern of glomerular injury. And since the last guideline in 2012, the etiology of many of these glomerular diseases that often have an Mpgn histology is much better understood. The Mpgn pattern is often occurring in the setting of glomerular deposition of immunoglobulins. That means immunoglobulins that could be monoclonal or immune complexes and complement, or in the setting of a dysregulated alternative complement pathway. We suggest that the old nomenclature of Mpgn type 1, type 2, which is also called dense deposit disease, and type 3 should be abandoned. Now, because we now realize the heterogeneity of all of what was lumped together as Mpgn in the past, we really don't have any good randomized clinical trials on which to base management recommendations for specific etiology of Mpgn. So different than in most of the other chapters of the guideline, only practice points to help management will be discussed in this particular section as we await clinical trials for more convincing randomized controlled data and then recommendations. Having said that, I think this is perhaps the most important figure for the Mpgn histology. We use immunofluorescence to classify Mpgn and develop a differential diagnosis. And that defines the direction of the diagnostic workup and subsequent treatment. So, based on immunofluorescence or immunoperoxidase, Mpgn pattern disease can demonstrate immunoglobulins with or without complement, can be complement dominant, or can be negative for immunoglobulins and negative for complement. In this particular category, which we're not going to discuss, a number of disease entities should be considered. Thrombotic microangiopathies, both antiphospholipid and HUS, sickle cell anemia, and others. The main disease classes that we're going to consider now are immunoglobulin or complement dominated. So if you have immunoglobulin or immune complex disease with an Mpgn pattern, consider a monoclonal gammopathy. Consider autoimmune diseases, for example, lupus being classic. Consider an infection-associated glomerular disease, especially hepatitis B or hepatitis C, endocarditis, visceral abscess, parasitic infections. Very rarely, at least in adults, are these diseases idiopathic. Most of the time, it just requires looking for an etiology. And you can see that if you proceed with an immunoglobulin or immune complex workup in this nature, and you find what is associated with your kidney lesion, then this gives you a good idea of how to treat, because the treatment of the kidney disease, of course, is treatment of the primary underlying process. The sticky part is how to treat something that's truly idiopathic, and we'll discuss that in a minute. In the complement-dominated Mpgn, these are alternative complement pathway-mediated diseases. We divide them into C3 glomerulopathy, which is comprised of what looks like the old dense deposit disease, but it's the C3 dense deposit disease, which we now know is a complement-mediated disease, or C3 glomerular nephritis, in which there are no dense deposits. A newer entity called C4 glomerulopathy has also been described in a few patients, and the same consideration is given for its manifestations on histology and electron microscopy. So here's the algorithm makes it look fairly straightforward, but there's several important diagnostic pitfalls. First, if no underlying etiology is found for an immune complex mediated GN with an Mpgn pattern, after extensive workup. So you've gone through the left side of the algorithm, gone through all of the diseases. You can't find infection, you can't find a monoclonal protein, you can't find an autoimmune disease. Evaluate patients for complementus regulation. So it turns out that complement may actually be dysregulated in immune complex glomerular nephritis. Classic C3 glomerulopathy could masquerade as an immune complex glomerulonephritis, especially if the C3G was triggered by a preceding infection or even a concurrent infection. Practice point number 2, rule out infection-associated glomerulonephritis or post-infectious glomerulonephritis before assigning the diagnosis of C3G. So again, that goes along with what I just described here. C3G can be triggered by an infection, and if an infection is ongoing, then of course it should be treated. The last very confusing practice point that should be kept in mind or can confuse the diagnosis is evaluate for the presence of a monoclonal protein in patients who present for the first time with a C3G diagnosis and they're older. So C3G is generally found in children and young adults, often because there are genetic components or polymorphisms in the complement proteins that regulate the alternative pathway. However, it's also been found there's a couple things to consider. First, if you need to exclude infection and monoclonal gammopathy because immunoglobulins may be masked in cases that look like C3G, and you only see the complement by immunofluorescence or immunoperoxidase. If you pronase the tissue, so you enzymatically digest the tissue, it reveals the immune complex portion. So this should be considered in most cases of C3G by your pathologist. The other important point to remember is that monoclonal proteins in and of themselves may be able to activate the alternative complement pathway and trigger what appears to be a C3G, but the patient has an underlying monoclonal gammopathy, and treatment would be considered different. Now, functional complement activation evaluation is important in the Mpgn histology-based diseases, and a lot of these are done at specialized centers throughout the world, but you have to quantify complement regulatory proteins and complement factors, including factor H, factor B, properidin, etc. These specialized centers will also measure complement activation products, such as the final common pathway products of MAC. These patients could have autoantibodies to regulatory proteins, these nephritic factors that activate complement, so those need to be examined as well. And then genetic testing should be done for polymorphisms in several complement components as indicated here. Again, this is not done routinely in most laboratories and is often a send out to a specialized center. Several practice points on the management of immune complex glomerular disease. So when ICGN, the etiology of ICGN is determined, the initial approach should focus on the underlying pathologic process, and we've discussed that. Indolent ICGN, whether idiopathic or linked to a primary disease process, is best managed with supportive care and only very carefully considered use of immunosuppression. So it requires a good evaluation of activity on the kidney biopsy. And if there's not activity or not very much activity, use of immunosuppression may actually impart a higher risk than simply good supportive care. For patients with idiopathic IC-GN and proteinuria less than nephrotic range, in the absence of nephrotic syndrome and a normal renal function, or EGFR, again, supportive therapy with RAS inhibition, renin-angiotensin system inhibition alone, is recommended or suggested. If patients have idiopathic IC-GN in nephrotic syndrome, normal or near normal serum creatinine, a limited treatment course of corticosteroids should be tried. And in patients with idiopathic IC-GN, abnormal kidney function, not with crescents or rapid progression, and without nephrotic range proteinuria, corticosteroids plus an immunosuppressive should be tried. For patients with rapidly progressive idiopathic IC-GN, immune complex GN, high-dose corticosteroids and cyclophosphamide should be tried. So as you can see, this set of practice points really is geared towards the management of the few cases that you'll find of idiopathic immune complex glomerulonephritis. More likely, if you dig hard enough and look at the patient in depth, you can find etiology of the immune complex glomerular disease, which will allow for more specific therapy. And finally, for the management of C3 glomerular disease, this is very opinion-based. There is not a lot of good data. In the absence of a monoclonal gammopathy, in the absence of infection, C3G in patients with moderate to severe disease should initially be treated with mycophenolate. There are some data showing some responses in patients with C3G, and especially in those patients who may have a nephritic factor or an autoantibody to complement proteins. If this fails, eculizumab has been tried. Patients who fail to respond to any of those treatment approaches should be considered for a clinical trial where available. And I guess the main thing to convey regarding the management of C3 glomerulopathy is that in the last year to 2 years, several clinical trials have been started, often with complement antagonists for the management of C3G. So it's possible that in the next few years, we'll again have to revise the guidelines with an update when we have solid randomized controlled data as to the management of C3G. And with that, I think we're done. I thank you for your attention. The guidelines will hopefully be coming out for public review in the next several weeks, and then hopefully for publication in the late spring to summer. Thank you.